but we really have an opportunity to together look at the work through the lens of the people that we serve, and even through our own lens, because at some point we too will be patients or have been patients. So it is important to put everything in context as we'll talk today about implementation of surgical care, that we look at it from the perspective of the journey that patients make. And that journey takes them throughout moments of emergency or critical care, and certainly surgical care. So it makes us start thinking about a pathway that we should all aim to deliver and facilitate for people. And we also have an opportunity to hear from leaders of entire health systems here today, the ministers, the directors, who have in their suite of responsibilities the enormous chance to look at how they build and integrate health systems. So many of us look, a colleague, leader also of the Ministry of Health of Vietnam a few weeks ago at the World Health Summit said to me, sometimes you look at the work that you do one patient at the time, one patient at a time. And if we do right by that patient every time, we will feel good about it. But those who are at the level of ministry are having to look at entire populations at the time. So it is important to continue to look at that level of integration that supports people. It's been a great few days, so many events that help us highlight the commitment and the opportunity that all of us and your organizations make to those who need surgical care, critical care, emergency care, all through the eyes of the people we aim to serve. Operation Smile and Mercy Ships are really pleased to welcome you today. And someone today, I believe it was Christine, asked me, so why did you decide to do this together? And it occurred to us that it started very organically, just with a conversation with a colleague and a deeper conversation with a friend about what it is to truly partner and what do we work for. And it evolved into an organic discussion of can we together bring to the forefront the voices of the health workers and the experts who are every day trying to make a difference in the people that they serve. Today we will begin by showing a very short trailer of about 3.5 minutes. Those of you who were at the event, wonderful event put together by the Incision, got a little bit of a peek. I'll give you a little bit of more background. This trailer is the trailer of a documentary produced by Dylan Williams, who's a highly awarded documentarist, whose impact and focus is usually not on health, but he got interested in the stories, in the human stories of the people who look for care and the people who care for them. I ask you to look at these 3 minutes and reflect on the type of interactions, the type of setting, the type of challenges, the type of drive and commitment, and the families and the people and the workers and the leaders who make health possible for their own communities every day. I will ask if you wouldn't mind to help us play the trailer. It'll take a few seconds. Please enjoy.
This is bad. Nuko aka kaguru tugakatira munsi y'ivi.
Plastic surgery here is function. It saves lives.
A lot of patients were there, but hospitals were not having doctors.
So I just said, why not me?
When I went to the hospital in the first days, I was really scared.
What's the issue? Is the patient okay?
Honestly, I did not want to be a plastic surgeon at the beginning. These are long days. You always expect that they are going to be long.
Today you can do 10 patients, tomorrow you see 20. That's where the debate is here today. What will happen if we don't do?
Just kind of safe.
You can do almost everything. You can cut here, move this, move that. It's magic.
It gives you a sense of purpose. Craniofacial surgery deals with deformities of the head. But so far, we don't have any craniofacial surgeon in the region. Toronto is in the top in training of craniofacial surgery. But for now, I'm going alone. I had a feeling like I was leaving them behind.
We pretend to be rocks, but sometimes you crack. Unfortunately, we lost the kid.
Am I really going to make it? How many women are you seeing in surgery?
An empty house welcomes you. You cannot share how good or bad the day was. Is this worth it?
Katira ça va être kuvurire sibyo noneho tujya kwiga tera uniform good ni sawa cyane
Sorry, Nga.
I feel the sense of hope for the future because we are resilient people.
Today is a tie day. It's all about a mindset. That's what makes you a surgeon.
Because if you're not passionate about it, you'll not do it, trust me.
Thank you so much. This is an example of a program that Operation Smile supported under the leadership of Professor Fausting. And it's an example of a locally driven, international supported program that Mr. Williams was able to showcase. And when we shared this with our friends at Mercy Ships, and we asked if they would allow us to share it, they said absolutely yes, because this story repeats itself. And if you can see, there's no flags, there's no logos, it's just a story of the people who make it possible. Today, we will be hearing from Professor Fausting as well, who will be leading a panel. But as you see the struggles and the fight and the joys and the opportunities and the ups and downs, nothing gives us more joy than seeing leaders of countries standing up to take care of their own. So it is really pleasing today to welcome His Excellency, Mr. Kawabena Minta Akando. And I would say that 2 years ago, we were at the airport here in Geneva on the way home, and we had a wonderful conversation. I had no idea that he will soon become the Ministry of Health, but it was truly a joy to just talk about life, about commitment, and it is wonderful to see leaders like him take on such important tasks. Welcome, Honorable Excellency.
Thank you very much, my friend and brother, Your Excellencies, distinguished colleagues, development partners, ladies and gentlemen. I really wish I could stay throughout to actively participate in the conversation. But as you all do know, once you get to WHA, I mean, your program back to back, some even overlapping and what have you. As I stand here now, I have about 3 programs simultaneously going on. And so from here, I'll have to quickly rush to another program. So forgive me if I attempt to exit this hall. It is truly an honor to be here with you today at this pivotal moment for global health. I stand before you on behalf of the government and people of Ghana to share how we are translating our commitment to concrete action through the implementation of our National Surgical, Obstetric, and Anesthesia Plan known as NSOP. Globally, it is estimated that over 5 billion people lack access to safe, timely, and affordable surgical care. This is more than a health system challenge. It is a matter of equity and justice. After navigating a number of domestic and global delays, Ghana launched its NSOP in September 2024 with strong support from partners including Operation Smile and the World Health Organization. This plan is fully aligned with our national commitment to universal health coverage and Sustainable Development Goal 3. Our NSOP is built around 6 strategic pillars. 1, service delivery, infrastructure and equipment, workforce, governance, and leadership. Information management and research, finance. Our vision is clear and ambitious: to ensure equitable access to essential surgical care for all Ghanaians. What have we achieved so far in less than a year? We have established a 16-member implementation steering committee and appointed a desk officer at the ministry to coordinate NSOP delivery. Over 150 health facilities have been assessed for surgical readiness. We have procured critical equipment, including oxygen plants and operating tables. More than 300 surgical providers have been trained. We have started integrating surgical indicators into our DIMS and light wave information system. And to retain skilled professionals in underserved areas, we plan to introduce 20% salary incentive for health workers posted to our rural areas. Our NSOP is not a para initiative. It is embedded in our health sector medium-term development plan, our annual budget and work plans, and collaborative effort with key actors such as Ghana Health Service, National Health Insurance Authority, Ghana Medical Trust Fund, the Ministry of Finance, and others. This multi-sectorial ownership is what transforms good plans into life-saving actions. On infrastructure, we are making critical investments. Oxygen plants are being procured and installed in all 6 teaching hospitals and 16 regional hospitals. Standby generators are being distributed to over 261 surgical facilities. Operating theaters in rural hospitals are being upgraded. And with the support of Kofi, we are training biomedical engineers to maintain these assets. This infrastructure is the backbone of surgical care. On workforce, we are implementing a tax shifting strategy to expand the surgical capacity of non-specialists. We are growing residency programs and working with the training institutions to build a new generation of surgeons and anesthetists. For Ghana, human resources are not just one component. They are the heart of our NSOP. We are also making progress in monitoring and evaluation. We are integrating surgical indicators into our national health data systems. A real-time surgical dashboard is under development. We are embedding NSOP reviews into national performance monitoring systems and recently hosted our first Ghana Surgical Dialogue to institutionalize accountability. This is how we turn the data into direction. Of course, we have had challenges: data gaps at the facility level, delays in infrastructure disbursement, and the need for stronger coordination across regions. But we are learning fast, and we are moving forward with purpose. Most importantly, we have seen that when partners align with the national vision, implementation accelerates. Looking ahead, we estimate that from 2025 to 2029, ENSOP implementation would require $1.5 billion US. This funding will come from a blend of government capital expenditure, public-private partnership, and development partners' contributions. On our next steps are clear. Finalizing the ENSOP M&E framework, scaling implementation and subnational levels, expanding private sector participation, strengthening capacity building and surgical research, securing sustainable financing, and continuing the expansion and upgrade of health infrastructure nationwide. In conclusion, surgical care is a smart investment. It is not a luxury. It is a necessity. Ghana is demonstrating that with leadership, coordination, and commitment, we can move from policy to practice and from promise to results. So today, we call on our partners to align with national surgical plans, prioritize surgical care in global funding strategies, and most importantly, walk this journey with us side by side. I thank you for the opportunity. I cannot conclude my statement without thanking Operation Smile and Mercy Ships for the wonderful work they are doing in Ghana. I am a member of parliament in a rural area. This is my 4th time in parliament. And so we have direct dealings with the grassroots. So I know what it means to do free surgery for a small boy who cannot go to school. I know what it means to do free surgery for that adult who cannot walk to public places. As members of parliament in the part of the world I am coming from, our dogs are almost all the time being knocked for assistance for such procedures. And so when you do it for that young boy or that adult, you do it for me. You have no idea the pressure you take off us. So we appreciate so much the work you are doing in our country, and we look forward for more. Thank you for the opportunity.
Honored by your words and your kindness, Your Excellency. And we know you have to at some point depart, but we're thankful that you were able to make it there. And also we have members of your delegation with whom we've been able to work very closely, who we respect and honor and thank as well. What a message. I do have to also highlight that as some of this work happened and discussions were being carried out, 76.2 was coming into place and maturing. And as we look at a global strategy, the plan that was generated in Ghana does include emergency critical. So it goes back to the integration that we look to offer our people. Honored to have you, Minister. Thank you very much. Big applause from the Minister as he departs, please. And I have the privilege of calling Distinguished Director of Health Services of Vietnam, Dr. Nguyen Trong Qua. And Vietnam is one of those countries that has been committed to safety all throughout, surgery, emergency, critical, going back to the days in which 6815 was approved. Recently, we had a discussion with Dr. Goa, who has a big job at the Ministry of Health. And he said, I care about, most of all, about patient safety, patient quality all throughout. It is a privilege to have seen and witnessed the work of Dr. Goa over the years. Have the privilege of meeting him now for more than 10. And he promptly reminded me that back in 2015-16, we were in Holland Bay doing a little bit of karaoke. You have to do the work, but you can also have some fun. Honorable, please join us on the stage, and thank you for your work.
Thank you, Ruben. I'm sorry, I'm speaking English not very well, so I would like to share some experience working with and collaboration with Operations Smile and for the long time. As you know, Mutual Health and Operations Smile, firstly, not directly collaborate with Mutual Health, but through some hospital like dental hospital. First, with every year, the Operations Smile support and bring many doctors, nurses from the organization to have the surgery for the children with cleft lip and cleft palate. Each year, more than 2,000 children with life-changing surgery. So it changed their life. And I think it's not only the technicals in the healthcare, but also bring to them the life. So through the collaboration between Mutual Health and Operations Smile, we also have the chance to the medical doctors, nurses, and anesthesiologists, students to training, to learn from the experts from Operations Smile. For some years, for the beginning, they do the surgery with the support trained from the expert from Operations Smile. But for some year, when they have the experience, they can join with Operations Smile to do some surgery in other country. And I think it's a very good chance for them to improve the capacity and skill in surgery. And not only surgery for cleft lip and cleft palate. Operations Smile help us to develop the surgical safety criteria safety for the hospital. So this job is cooperate between anesthesia and surgeon committee to cooperate to develop this criteria. And so I think it's very important for the safety in surgery. This helps us reason when one organization, not Operations Smile, they do the surgery for in the middle of the Vietnam, Khánh Hòa, in Nha Trang, you know, Nha Trang is the middle of Vietnam, and one organization they do the surgery for children with cleft lip and palate. 3 children die. This is a very serious situation when they do the surgery. So it's safety for the children and safety for surgery is very important. So after have this information, the Operations Smile already help us to develop the surgical safety criteria and training for many anesthesiologists and surgeons and nurses in Vietnam. And we use this criteria to check all hospitals through the 8 components. For example, the basic condition, the procedure, infection control, and other conditions for safety for surgery. So I think this is very important, not only for some surgery like cleft lip and cleft palate, but also for all the surgery. And now we still use this criteria to check every year for hospital. And for our experience, we continue to integrate surgical care into the nation and sub-nation health priority. Now we have developed the private sector, more than 300 private hospitals, around 25% of hospital is private, and now they cooperate with between public and private collaboration. And the partnership between Ministry of Health and Operations Smile demonstrate how NGO can align their work with the national priority. And health can have access to surgical services without creating parallel system. And investment in the human resource for surgery through continuous training and mentoring program. We are building a new generation of skilled surgical provider, especially in pediatric and reconstructive surgery, who can serve in public hospitals across the country. And I think more than 100, some hundreds of surgeons and anesthesiologists already trained by Operations Smile program. And I think it's a very, very important resource, human resource for our surgical care in Vietnam. And it's not only for Operations Smile collaboration, they can do another surgical in Vietnam. For example, for cardiovascular disease in children, they also have the skill to do after some more training for specific specialists in the surgeon in Vietnam. Thank you very much, and I think I thank you much to invite me to have the express my thank about the Operations Smile for the thing you do in Vietnam. And I think you can help other children in the other country like Vietnam to have the new life. Thank you.
Thank you so much, Dr. Khoa. And we have the privilege of having worked in Vietnam for now 30 years. And what does a cleft organization have to do with a whole entire system? But at some point, we did work on the safe surgical guidelines. And at some point, Dr. Khoa and others said, well, maybe we should look at the critical care guidelines. And this is where we say, well, where are our friends? Because that's not something we do. Terry, Lee, anyone around here, anyone? So there's opportunity for ongoing engagement with so many other sectors and collaboration and support of leaders like Dr. Khoa who are advancing. At some point, we are expecting, we also, my welcome the Minister of Health of Sierra Leone, who works very closely with Mercy Ships, and also potentially the Minister of Health of Zimbabwe. So if they come in, we'll introduce them into the program. But now a very important announcement. I was told you wanted the password for the Wi-Fi. and I assume that is because you're going to tweet or put in LinkedIn. No, anyway, it's Warwick with capital W 2025. Very difficult, very difficult. Warwick 2025. It is impossible to do this work if we don't include multiple sectors. And one of the thrilling areas for any NGO is that if you can be a conduit to trust between governments, philanthropies, private sector, and many other groups as we engage with communities. So it is with that notion that I'm very thrilled to welcome Mariana Anselmo, who's the General Secretary of MSC Foundation, who's been a supporter of Mercy Ships and also Operation Smile for many years, as an example of what an entity like yours can do to empower us to do more. Thank you so much. Welcome.
Okay, thank you, Dr. Ayala. So, Excellencies, distinguished guests, friends, and partners, thank you for the opportunity to introduce this important panel discussion today. My name is Marina Anselme. I'm speaking on behalf of MSC Foundation, the philanthropic arm of MSC Group, a global leader in shipping, container transport, and inland logistics, but also in the tourist industry through cruises. The MSC Foundation is the philanthropic arm of the MSC Group, headquartered in Geneva for over 55 years, led by the Aponte and Vago family. The foundation was created in 2018 with a vision to restore the critical balance between people and nature within a generation. Our mission is to harness the MSC global reach and unique seafaring knowledge to act for our blue planet and all its people. MSC has a long history of corporate giving, but our foundation was created just 7 years ago to enable more structured efforts directed to tangible impact and with the freedom to engage in philanthropy independently from MSC businesses. Even if the foundation is still young, our commitment runs deep. Started off operation late in 2019, the Foundation for the Oceans became at one point a foundation very helpful for addressing some of the needs during and within the COVID-19 pandemic. And that revealed the MSC family DNA, a deeply rooted sense of responsibility that allow us to shift actions in time of crises, benefiting from the maritime agility to bring tangible help and assistance to vulnerable communities everywhere where there was a need. We leverage the oceans to make a difference in the life of 2.4 million of people in need in the past 6 years, many of these being people affected by climate-related disasters and lack of access to quality and safe care services. As an example, we supported and we still support in Operation Smile free surgery on different countries around the world. We did and we do so since 2011, which and through in-cash donation, most of them has been channeled through the colleagues-driven fundraising efforts in the MSC USA office that reach out more than $3.5 million of support to Operation Smile. We also, since 2021, we have been transporting their emergency medical items to the countries where they operate. Similarly, we have been supporting Mercy ships with maritime operations to deliver free surgeries on their hospital ships port since 2010. We have been shipped so far till the end of 2024, more than 124 containers with all the items they need to operate, both medically, but also perishable and non-perishable goods. We have been last year, together with the commitment of the MSC Group, engaged in a journey of building the next hospital building that will be replacing the African Mercy in about 3 years from now. So the foundation with the company has been committed for 50% of the cost of that hospital, but most also importantly, we have committed and we are engaging in supporting Mercy Ship in the construction of such a hospital ship. Our commitment to solid and experienced partners such as Mercy Ship and Operation Smiles are rooted in our values of responsibility, respect, efficiency on our responses, empathy, collaboration, and the willingness to be meaningful in filling existing assistance community gaps in developing contexts. We are all aware of the growing gaps in global health funding, especially for surgeries and special care in lower income countries. Governments cannot do it alone, nor can NGOs, foundations, or the private sector. Our experience with the Mercy Ship and Operation Smiles is that through a mutual trust, a willingness to excel, share expertise, and by learning together, the partnership can evolve and also can transform. We believe that private philanthropy can play a significant role in catalyzing resources and expertise from the corporate side towards non-profit organizations working together with governments to advance the realization of human rights, such as is the access to free quality healthcare and surgeries. And this promoted jointly to common public good goals. The collaboration with both Mercy Ship and Operation Smile is an example of this good practice. Moreover, we strongly value Mercy Ships and Operation Smiles, whose engagement with national and local authorities is aiming at completing, supporting, and contributing to strengthening the work of Ministry of Health to provide safe and quality service with the focus of those most easily left behind. We understand that good health and healthy living conditions are enablers for the realization of other fundamental human rights. And this because, once again, and very clearly, I had the joy to be part of an Operation Smile mission early this year in Morocco, in Tangier, led by Fusha Mahmoudi. And it was very clear to me when looking at the different kids that were waiting to get surgery, how this connection between health services and health rights connect to many others. I remember one of the kids waiting to get surgery after living more than 7 years with a severe and multiple cleft lip that brought him to remain at home, quasi-isolated from anyone outside his family, because his face scared all other children. Mohammed was playing with a balloon throughout the hospital room and engaging every other patient to play with him. Mohammed got surgery early the following morning, and I had the opportunity to see him few hours after on the arms of his mom, who was in tears to see the transformed and beautiful face of his small boy. I asked her mom how she felt, and she responded to me, "I'm so, so happy for him, because finally he will go back to school. His backpack is ready at home since the moment we were called by Operation Smile to come to Tangier. It is waiting our return to start this journey at school. This is what Mohammed is waiting and expecting the most. Access to surgery, in many cases, is the only way to break a circle of discrimination, isolation, and unhappiness. It's open a myriad of opportunities for every human being to achieve their full potential, realize their dreams, and become active members of their societies. Indeed, it transforms lives. This is why multi-stakeholders conversations like the one happening here are so essential. They support common understanding, trust, and alignment we need to scale impact and transform lives. With that multi-stakeholder perspective in mind, I'm pleased now to hand over to our moderator and esteemed panelists. We at the MSC Foundation stand and remain committed to do our part. Thank you very much.
Thank you so much, Marinera. We're really grateful for your support and your commitment, and to hear your passion and based on experience is moving to us as well and encourage us to do more. You may not know, Mariana is originally from Argentina and her husband is from France. So I really wish her very good luck in the next World Cup. Let there be peace in the house. Not a chance I hear. My friend, Dr. Walt Johnson, has indicated that we have a message from the Minister of Health of Zimbabwe, which will be delivered by our colleague, Dr. Shiva Morangas Pillai. If Shiva is here with us, we're welcome to hear your words, and then we'll go on with the panel.
Good evening. I stand here in front of all of you on behalf of one cardiothoracic surgeon who coordinates or is supposed to be coordinating our surgery, obstetric anesthesia development in Zimbabwe. Unfortunately, he couldn't come because permission, member financing, and the Swiss are not very kind to us in visas. His message first is very simple. He has performed our cardiothoracic surgery in Zimbabwe, started as far as 1959. However, it stopped. We resuscitated it in 2018, 2019, did about 100, and we stopped again 2003. Thanks to his powerful commitment, he restarted it in 2023, 63 patients, and he managed to also engage colleagues in Egypt, and together they came out and did more. So his message is he wants to continue to do more cardiothoracic surgeries, especially congenital heart disease, and he asked me to pass this message. Please, I need help with the perfusionists. I need help with the cath tab. I need more collaboration with my professional colleagues wherever they are. So that's his message. He's a very dedicated person, but he works in a very difficult environment. I'll come to that later on. The other message I have here is from our INSOP team. We set up our surgery obstetric anesthesia after we launched it with my colleague here, Professor Makasa. Zambia and Zimbabwe were the main who launched the major resolution and surgery, essential emergency surgery. Please all look at it very carefully. Following that launch, we did a situation analysis and we developed the INSOP and launched it again in 2023. But the surgeons who took it forward got busy with their practice. The anesthetist came in and took it forward. And it was the drive of the anesthetist that we ended up with a surgery obstetric anesthesia plan. And they also mobilized WHO to also provide support and funding to get that first input. And we also had support from JICA. And we launched the first implementation in 2 provinces and 3 districts, and had surgical outreach teams going out, obstetricians, and doing various operations, hernias, cataracts, etc. That's where we got to. And the main message from the surgery obstetric team is we are struggling to establish a national hub, which a great model has been established in Zambia, because our biggest challenge is getting all the professional organizations, the surgeons, the obstetricians, the anesthetists, the ophthalmologists to come onto one platform. And even the maxillofacial. We do cleft lip, but some of the maxilla, and there are different teams doing different things. And we also have support from Rotary. They come and help us in hydrocephalus and other camps which are going out. So bringing everybody together in a coordinated manner. The university is not helping us. The ministry is struggling. Last year, we had our ambassador here, our PS, who is a surgeon, as well as our minister. And they spoke eloquently for a long time. But when we get back, the political commitment is lost in many challenges. Right now, we have a big funding crisis. It's a debt problem, sanctions, plus the US government has pulled the plug on us. So we are struggling to readjust and cope with the basics. So the NSOP is moving forward, but the main key issues is the request. We have a proposal to get our teams from the central hospital or provincial hospital to go and work with the district medical officers and nurses who do our anesthesia is done by nurses. So our target is to help them get the bellwether projects going. In most districts, basics are ectopics and cesareans, then the hernias, etc. But if there's no hand-holding for the general medical officers and the nurses by outreach to build their confidence, competence with a bit of the equipment and others, so the outreach side of it. Finally, I have a very interesting proposal which we discussed last year. Mercy ships provides a mission and a vision. Those ships are now anchored, I understand, in Madagascar and Sierra Leone. I hope they are moving to Tanzania and moving to Gambia. And what is going to happen there is going to be a more scale up of universal access to surgical services when they go there. It's just not the camp. So that's one. Second is Zimbabwe is a landlocked country. So we don't have any sea, and we can't imagine the mercy ships anchoring, but we have one of the biggest lakes in Africa. And we share it with Professor Makasa. I mean, that's our comradeship goes back there across the Zambezi. So we have done a bit of groundwork. We are coming up with a district outreach from our provincial hospitals, surgery obstetrics, and a hospital board to increase access in the remote areas along the lake. But that's going to combine with our tourism industry and the fishing camps and the energy industry. So we hope they will also support us. So that's the project proposal which is there. It's an innovative, new one, but the results should be is increased access, lower surgical waiting lists, and very competent, empowered district medical officers and nursing staff and others in those districts. So that proposal is there. Our apologies, we had slides, but due to various logistic, but we'll prepare and finish those slides and share it with all of you, and that's a promise. Thank you.
Thank you very much. Shiva, you had slides? So my dear friend Walt Johnson said, Dr. Shiva's going to speak. And I said, as long as there's no international incidents, and we started with the Swiss. So we'll delete that from the record. but all jokes aside, what we do here is a plea to pay attention to needs and to the opportunity for collaboration. And maybe that's a calling that we should listen to and pay attention to. And it starts with our own organizations all the way to the engagement for the World Health Organization, the many partners they have brought together to look at entire systems and to support the patient's pathway to care and so much more. We all can come together and do something about this. Thank you so much for your time. All right, so we have come to the moment of our panel discussions, and we do have a great panel. And I'm very excited to introduce them. And I hope that you are tweeting like crazy or LinkedIn like crazy, right, with the passport. But you saw the video, and I think that if we get the panelists up here, it's going to be, the light's going to be in their faces. So if we don't want to punish them for giving us their time and helping us. But I'd love to welcome my dear friend, Professor Faustin Niteranganya, who is the current chair of the Rwandan Surgical Societies. He's a medical director of Operation Smile. He is at the University of Rwanda. He has many roles. I don't know when he sleeps, but he's certainly a driver. And you witnessed the work that he and his team do in Rwanda when we watch the trailer. Professor, please welcome. He will be moderating this panel. Please come on top to the podium. Big applause for him. I would like to call, we start with Dr. Carolina Haylock-Lord. Carolina Haylock-Lord is incoming president of the World Federation of Societies of Anesthesia. She's a compelling advocate for the safety of patients. She's originally from Honduras, so you'll often see us in the hallway speaking Spanish, and having a great old time. But she has a long track record of teaching, of quality, and of engagement and the leadership, not only in Honduras, but around the world with the World Federation of Societies of Anesthesia. I would love to welcome now Professor Makasa, Emmanuel Makasa. We all have come to know Professor Makasa for many years, originally from Zambia, global health diplomat, constant advocate for safe surgery. I would like to call now a dear friend, Professor Dr. Barnabas Allende, who is one of those voices. You might have heard him a few days ago, making sure that we did not leave the patient's voice out. He is a faculty member at the University of Global Health Equity. He's with the Center for Excellent Equity in Global Surgery, and he is also a mentor of the Global Surgery Advocacy Fellowship that has given many people the chance to answer them. I'm going to ask Professor Nima Kasiji, who is a pediatric surgeon, a humanitarian surgeon, health leader, and expert in health systems. She has worked in many countries: Haiti, DRC, Central African Republic, Nicaragua, and Liberia, and some of them we've gotten a chance to work together. And she is now leading a surgery, an operating room at the Kakuma refugee camp, a project she launched in 2020 during the Davos meeting. And last but not least, we would love to welcome Dr. Terry Reynolds, who you all know, but she, I keep bragging about her. She was a recent inductee of the National Academy of Science. It's one of the highest honors a scientist could receive. She very humbly admitted it at some point. We almost had to pull it out of her, but she is she leads the Clinical Services Institute Unit in the Department of Integrated Health Services at the World Health Organization, and she will consistently remind us about the importance of looking at the entire patient pathway and our primary health care approach to health systems. Dr. Reynolds, please. We will leave you then with this incredible group of panelists. Please enjoy things.
I have one. Good afternoon. So welcome to this panel. Maybe I'm going to start by asking one question. Barnabas, can you exchange the seat with Terry? Oh, good. Thank you for accepting. So when I was listening to our colleague from Zimbabwe speaking shortly, then I was probably introducing us in our discussion of today, where we're gonna discuss and focus on implementation and implementing surgical care. And as many of you may know, these past weeks and probably a few days from now, we were celebrating 10 years of global surgery movement. So many papers are out there, and if you summarize them, they describe a lot of definitions, many metrics and data. But some voices are coming out there and are saying little has been done in terms of impact, in terms of impacting on people's lives, in terms of addressing the real challenges and the real issues. So in other words, it means we have been speaking and doing less. So now, let's start by Nema. How far do you agree or disagree with that statement?
I'd like to split my response in two, if I may.
Sure.
So I think we have made progress in terms of defining metrics, in terms of understanding the extent of the problem. You know, it's 5 billion people who do not have access to surgical services. And in order to advocate and to get people on board, you need that data. But we could do more from an operational standpoint. You know, so behind that 5 billion, it's women who are pregnant, who need life-saving C-sections. We mentioned children with congenital disorders who've never been able to go to school because of how they look, or because they don't, they need those surgical services in order to integrate into society. So on the one hand, we have made progress in terms of understanding the scope of the problem. But on the other hand, we need to do more. We need to do more, reaching people, especially in conflict areas, in rural areas. That's where my focus is. And when we talk about access, it's not enough to just have access to surgical services, Because if you give access to poor quality surgical services, your outcomes will be worse off. So we need to make sure that it's access to high quality surgical services in order to actually improve outcomes. So that'll be my response. So a mixed report at this point.
Thank you very much. So if I understand you well, so you're saying that we made a diagnosis. So Barnabas.
Thank you very much, Prof. Austin. There's a Ugandan proverb that says if you don't know where you are going, any road will take you there. And so it's just natural. I agree. And not just I think 32 African ministries of health came to this diagnosis in a very systematic manner in 2023 at the Pan-African Surgical Healthcare Forum. That there is a lot of defining. We have defined our indicators. We have redefined our indicators, and we probably are still redefining them. We have defined what competencies are around global surgery. We have redefined those competencies, and we probably are still redefining them. And this is important. In fact, it is essential. If you check any framework for building global health movements, you check any framework, even the PDSA cycle, for instance, for improvement, the first thing is to really define the issue and understand where you are going. And so I absolutely don't think that there is anything wrong with that defining. But the problem comes where you're changing diapers at 10 years, for a child. Right? It comes where we continue to define without really moving to what the next steps are. But even with the issue of defining, we're talking about the fact that we have defined. I want to bring another thought, that though we have metrics, though we have defined, if you check the World Development Indicators, the reporting has gone down to 0 since 2018 for 3 or 4 of those indicators. So really, how well are we defining? But the issue now is implementation is key. And I think that that's the direction that the whole global surgery movement is moving on to. My thoughts.
Great. So I like the Ugandan proverb, but there is a Rwandan one, and that one says, if you draw the cow quite longer, it ends by becoming a goat. So now, from our anesthesia colleagues, so if we are in all this together, and what is your take on this?
Well, thank you very much. While global surgery movements give us metric definitions and data collection, I think that is the north, because that was the north when we receive all this information. Because with that, we could get some tangible solutions or support tangible solutions. So evidence from case studies or from systematic reviews shows significant impacts. We could have been lost without the north. So that was, for us, that was the north. Improve surgical outcomes, increase access to care and sustainable partnership, especially in low-middle income countries. As an anesthesiologist, I can tell you that I see robust integration between research and action. This had led to real changes in not only in anesthesia, but also surgical care. And that's, for me, that's all this capacity that has been improved, that is something, that is part of the result of this data, these indicators, this metric, so I can say that part. So not only this global surgery movement presented disparities, but also try to address disparities, enhancing capacity, integrates surgery and anesthesia care into global health agendas, and that was key. That was key. So now we have awareness. What's going on? If it wasn't by that movement, we couldn't have that. So now we can move like with the North. We have been doing it for 10 years, but we continue doing it. So the present is, like the sum of all the past. We can't say yes or no. I say we are all part of this present. So that will be my answer.
Yeah, thank you. Maybe before I move to Prof. Makasa and ask the same question, maybe I'm going to add another one for you because you have been there when people started defining. So what is global surgery?
You want me to define global surgery? Well, global surgery is a field of work that aims to improve access to safe, timely, and affordable perioperative or surgical care for all individuals that need it. It has specific activities like advocacy and global health diplomacy, policy formulation and implementation, service delivery starting from prevention all the way to palliative care, education and training of providers, and global health research. That would be my definition.
See, it's very simple. So why this should take 10 years so that people understand all those details? So, Dr. Terry, so linking this definition, linking about what the colleagues were describing, and linking about the concepts. So how do you put it and how do you see it and appreciating the work which has been done so far and probably linking about the current trends and opening up for the future?
Is that all?
These are just that.
checking. So look, I think it's a really interesting moment, this 10-year mark, and taking that as an opportunity to sort of reflect and reckon. So first of all, that's a very interesting movement. I think there's two really key points. I think it is generational. And I think if you ask one group, has the promise of this been fulfilled? Is it still there, et cetera, you'd get quite different answers generationally. I think there's an entire generation of fellows who are now young professionals and will soon be mid-career, who had pathways and experiences that they would not have had without the opening of this space. I also want to point out the fascinating combination of having defined indicators described as the North Star and as changing diapers. And I think that's probably fair in terms of how much good indicators can do you at different times. So it depends on where you sit and what you're trying to do as to whether or not defining indicators is a threshold milestone. It's astonishingly powerful in some contexts. And then in most countries, there are many, many people who deliver the care who don't really engage directly, consciously with indicators. And that's true across every health system and every specialty. I also would ask you to think about it as like, there's a lot of, it's easy in a moment of reflection in 10 years. I don't know anybody, literally anybody, who looks back and says, have I accomplished everything I wanted to accomplish 10 years ago? I don't know anyone who answers that question by saying, yeah, I did it. So consider, the self-criticism is useful, the self-reflection, and that's what indicators are meant to do, right? Is hold us accountable. So the whole thing, that's good. But consider the possibility that it isn't a matter of small achievements, but it's a matter of big dreams. So if you took everybody's dreams about what global surgery was going to be 10 years ago, could anyone, anywhere have fulfilled them all? So the gap between where you thought you might be and where you are, it's never only negative. It just kind of leaves room to go along further. So these were very big dreams. And I don't think the fact that we are still on the road to achieving some of them means that the achievements have been small. So I think that's very important. And that may sound like a, you know, its own kind of proverb. And I can't bring you any lovely proverbs because I grew up in Texas and almost all of our proverbs involve profanity. And now that I'm a professional diplomat, no longer allowed to do such things. And I would just say I think the way to ask yourself that question that is very, very important, it came up earlier, and it came up in the documentary, actually, at the very beginning, and it was the question of what will happen if we don't do. So I think maybe a more hopeful way to ask yourself that question, a kinder way to reflect back on this decade, is to say, what would have happened if we didn't do? So, and I think if you ask that question of the younger generation in this room, you will find a very powerful answer that many, many, many of them took paths they would have never taken. So I actually see it as quite a hopeful moment. That doesn't free us from the discipline of hard self-reflection and continuing to set difficult milestones, but I do think there have been extraordinary accomplishments that deserve to be looked upon kindly.
Well put. Yes. So if we are going to continue that line, and I'm going to come to my colleague here, Prof. Makasa, I'm trying to understand. If I understand it well, so my colleague are saying that a lot have been done in the last 10 years. It laid the foundation, and probably we are going to move faster now because the foundation is strong and is there. But I want to be a surgeon on this panel, you know. So as surgeons, we like people, things that we palpate and we touch. We have to feel. So tell me, in terms of financing and sustainability of all this, what are the key achievements that you can highlight that we palpate for these last 10 years? Prof. Makasa.
Thank you. First of all, I would like to agree with my colleagues that we've made progress. Maybe we're a bit impatient with ourselves, but we have made progress. The first palpable or tangible thing is, first of all, the political commitments. We've had several political commitments starting from 2015 between the member states, 68.15, 76.2, not forgetting the decisions, the two decisions. That's quite impressive in a period of 10 years. And now these political commitments did not stay at the UN in Geneva. We've seen these commitments repeated at regional level, at sub-regional level, including country level, because nobody can finance anything without a plan. Even at home, you're not going to buy something and national plans usually are aligned to other health priorities. That's how they are designed. Alignment ensures that there is, mobilization or pooling of resources, or making sure that we're not working outside what we are already committed to, because surgery is not a standalone thing. Perioperative care supports all aspects of the health system and, in fact, health of individuals. There's also issues of integration. Not only integration into national health strategic plans, which are national priorities, but we're also now talking about integrating and ensuring surgical care or surgical services or perioperative services are also in the health benefits package at country level. Because the health benefits package is actually what a country will finance out of the essential service package that they may have. We've seen pooling of resources, all sorts of resources, human resources, expertise, by regions, the SADC being an example, where even to develop these plans required that we team up and support Zimbabwe, Namibia, Botswana, South Africa, Zambia. We have to, all of us as experts who know something, because developing a vertical program or a vertical policy is not the usual thing that member states have done. They've developed, horizontal policy. Most of the time they've done vertical program. They're experts at that. But something that sits all over the place is not easy to come up with. So they had to share that. Out of making joint plans, or for example, the SADC strategy, will make sure that these countries can also pool resources and mobilize resources together. And then there is also innovation. So we're not just talking continuing the same way, we have to innovate. Innovation, there is also, regional production of things. So, in surgery, you use a lot of things that have to be manufactured, sutures, blades, even IV fluids. So there's the issue of countries coming together to support each other so that they can innovate. And lastly, obviously countries develop their national plans, but developing a national plan and then thinking it can be implemented just like that at country level, nationwide, is not a possibility. So we've learned some lessons, and now we're doing things better, that when you make a plan, you also have to do the initial implementation. Like I said, you must generate the evidence. You must demonstrate the impact of how investing in surgical or perioperative care supports the health system to become stronger, how we contribute to improving on the health outcomes, and of course, above all, the socioeconomic impact that it will have on the people. So all these things in the end will help with issues of sustainability.
Great. So Barnabas, I think you are less and less politician than Makasa, So I need tangible things. In terms of workforce, let's say SR density, how do you compare then and today? What do you think is happening training-wise? How do we build the future generation of surgical care providers? It means surgeons, obstetricians, anesthesiologists, and nurses, and others. So please.
Thank you very much, Prof. If we look at the data, for instance, I'll take the East Central Southern African space. We've had since 2015 to 2025, we've had over 2,500 surgeons trained within that space. West Africa College of Surgeons is doing its thing. Pan-African Association of Christian Surgeons is contributing its part. Universities are also contributing, like the University of Global Health Equity, etc. We've had the 4x4 program, and in other words, quadrupling the number of medical professionals within Rwanda in 4 years. I mean, they're ambitious thoughts. So people are working. But if we come down to the metrics, right? I talked about 2,500 surgeons from then till now. When just earlier this year, there was some studies that were done, and they did the math with population. Although we had 2,500 additional surgical providers, the SAO density only rose by 0.06 because we are not matching population. So the truth is that we need to start thinking outside the box. We did some work around cardiothoracic surgery, looking at how long it will take us to reach what the needs are for the region. And in some countries, it's 300 years of training at this rate without considering population growth. How do you get there? So I think we need to start thinking creatively, leveraging technology. I know that now there's some attempts out of the Intuitive Foundation for self, arguable, but we have to think out the box. There's some attempts, again, at hub and spoke models, the use of telementoring. We just cannot continue to train the way we are training and expect to meet up the 12-point-something million deficit that we're staring at 2035. So I think it's going to take a lot more creativity. The Surge Hub, for instance, let's look at Progress. Surge Hub, for instance, has created a platform that virtually everybody can access. And we're seeing the impacts of that. COSEXA is working with the Center for Equity in Global Surgery, and we're doing something virtual. So we have to think outside, and we need to think creatively about who we train, and also think about reaching people at the undergraduate level to prepare them for surgical care, at least to a good degree at the district facility level. We have to think about where we train. In West Africa, there's a crisis of workforce because people are being trained in big cities and they're leaving. Honestly, they're leaving. But we see retention up to 97% on the continent in East Africa. Why? It has to do with a place-based education model where people are being trained in certain locations. Governments are thinking about what. So I think we just have to start shifting the way we think about training if we're going to make impact. Male-female ratio, yes, there are programs where we're building up female trainees for surgery. But again, taking the example of the Kuseksa region, the ratio has not changed. When we look at it it's still 9-1. So I think that yes, we have made progress, but the population is also making progress. And so we have to think critically about what the next steps will be. My thoughts.
Yeah, that's amazing. So once Einstein said that the definition of madness is to do the same thing and expect a different result. And I hope we are not mad. So, Nema, the same reflection, but now around infrastructure, equipment, that kind of assets. So if you compare, like the colleague was comparing, so the number of theaters that we had extrapolated to the population we had, and you compare by today, what do you see?
So reflecting on my experience on the ground, most recently in Kakuma refugee camp and in Turkana, a very rural area bordering South Sudan, Ethiopia, and Uganda. So more is being done in terms of infrastructure, and infrastructure tends to be very attractive for governments, because that's how they can get contracts in, and it's a way of bringing in business. So infrastructure, I haven't found to be an issue, and I've seen most hospitals actually having more operating rooms than they need. However, when it comes to, we're talking about equity and access, what I've found to be most important is financial protection and health insurance coverage. And we've just finished a pilot intervention where we were basically providing health insurance coverage for all the kids who needed surgical services. And that created more demand for services. That allowed us to unlock local financing. So for every dollar that we spent on health insurance, we're able to unlock $22. So surgical services can actually drive the different components of the health system. It can bring in new investments, from the private sector, from government, from multilateral institutions, because it requires a lot in terms of equipment, a workforce, and if you're able to finance that, you can bring in a lot of the building blocks of the health system. And so we've been able to go from a 7% health insurance coverage rate to basically 100%. 2 weeks ago, all of my kids had health insurance. And we're getting reimbursement. So we're also moving away from the charity model of doing things and making it sustainable over time. This has allowed me to get more specialists to also come, because initially they're coming to just do me a favor, and then they're like, no, we can't keep coming. So now I can tell them, well, no, you can come, do your 10 surgeries, invoice for those surgeries, and you will get reimbursed, so that it makes business sense for them as well. So that, I think, is key as we move forward, because we've defined the problem, we know what needs to get done, but who's going to pay for it, and how are we going to pay for it in the long run? And seeing what's going on with global health financing, we need to think fast and move to more sustainable ways of financing.
Yeah, so sure, and I agree with that, and I feel that, yes, the demand will create the service if you give people access. And I was counting the theater ratio In high-income countries, there are around 6.2 theaters by 100,000 population. So, and I did my exercise in Rwanda, and it is 0.9. So it means we have a huge gap infrastructure-wise. So if now we increase the demand, we make sure that ethically, if you tell someone to go to get service, be sure that you can provide it. But now providing services, they should be safe and of very good quality, because we shouldn't not be bending and having substandards. So that's why I'm coming to my colleague anesthesiologist, Dr. Carolina. So in terms of quality and safety, so how do you compare then and now?
Okay, thank you for that question. First, I want to say 10 years ago, it was a milestone with the 68.15 resolution. For the first time in history, anesthesia word was considered in a resolution. So that was, we had party for that, okay? So 10 years after, we also have party with the equal resolution 76.2 because anesthesia is, going across anesthesia care, going across emergency, going across critical care and operative care. So we are doing party for that too. And when we go to safety and quality, well, we published in 2018 the international standards for safe practice of anesthesia. And that give the whole world of anesthesia, the anesthesia family, another north, what to do, how to do, what was the minimum required. So that was very important. And so this international standards show not only the minimum or the crucial mandatory monitoring. You had oximetry, for example, okay? And so capnography now. But in those days, I remember simple things like how to carry my own oximeters to every facility. I had to do my job. So we got to do the zeroing in our oximetry gap in my country through all these efforts. So I am grateful for that. I don't have to carry it wasn't like an oximeter similar to this. It was a big 30 pounds, device. So it was really, really hard to go everywhere with that. So that would be one part. And now we're working with capnography, doing for the same thing. Also, some outstanding achievements, for example, Helsinki Declaration for Patient Safety. That came from Europe, but it was adopted by the whole world in anesthesia family. So making patient safe and, through any surgical procedure or anesthesia procedure. And also we adopted the APSF, the Patient Safety Guidelines, that also not only goes to, all these measures that you can do for having patients safe, but also it is mentioning like how to register events, if you have, but in low and middle income countries, sometimes that is difficult because you just thinking that if you report adverse events, that will be liable or, so we're changing culture and we're changing our way of mindset of thinking about that. Also, it's the integration of technology and anesthesia practice. As he mentioned, I think it's key. Recently, this month, it was published by the group of patient safety, APSF, the results of having anesthesia information management system, so we can get to know what was the rate or the range of complications and how we can modify those numbers. So all of those things will make a better world, a better practice in our side, a safe practice, and I think all of those will contribute to have better outcomes, less surgical site infections, less our better outcomes with, for example, blood health, treating anemia pre-op and then treating the patient during the intraoperative and also in the post-anesthesia recovery and also rehabilitation or recovery at home. So it goes, this system, electronic system, it's going to the 4 phases of the anesthesia care. So all those things is making a difference. And I think that is something that, yes, we are grateful for. Thank you.
Thank you very much. That was really very engaging and interesting, but my colleague there, Ruben, is calling me saying it's almost time. So we're going to wrap up this session and probably summarize our thought and then open to the audience later. But before we do so, Dr. Terry, if you summarize for us, and if you want to look into the future, if you heard what we were discussing, what was being done, what are we doing today, the patch, the rhythm, the issues, how can we move faster and better? And how do you anticipate the few years to come?
That's your second big question I want to point out. Look, there are a lot of different ways to look at this. I just want to focus on a few things that people have said. The way that problems are currently being described, the way that challenges are currently being described, financing, we've heard about service delivery, health workforce, products, Emmanuel's characterization of what is global surgery, that broad scope, that is exactly the marker of a mature agenda. So I used to run a residency program in Tanzania, and there was a point when we had a meeting, and it was a very unpleasant meeting, and all of the residents were complaining about schedules and this and that, and we had overcome a doctor's strike and many horrible, large-scale things. And they were complaining about schedules, and I was just like, I can't believe this. Why is this happening? And one of my colleagues from Europe was there, and he was like, look, that's the sign. This is established. This is exactly the mark of they're complaining about something that residents everywhere in the world complain about. So this is the thing. So welcome to the challenges of global health and health systems is what I would say about that. These are exactly, you've named all the building blocks, and Emmanuel's very aware of this, having worked as a health attaché for the entire health system. So this is a sign of maturity that these services are part of this discourse. So that's one thing I would say. The other thing I would say is you're absolutely right about, Barnabas, about thinking outside the box in terms of technology. I would argue that besides the pipeline of training, the other thing that needs that approach is the surgical backlog, because after COVID, which was one of the most influential things that has happened in this agenda in the last decade, in a number of ways for another conversation, but that is the other thing we won't overcome with anything like the current processes that we have. So the entire generation of people waiting for surgery will die in many countries unless we start doing something totally different. So we do have to think outside the box in that way, but I think this is also a moment for thinking inside the box. And what I mean by that is the things that Emmanuel listed around, there are certain kinds of evergreen concepts and processes, and that is really kind of WHO's bread and butter. So one way of looking at it is it's kind of the same thing and maybe slow and maybe big. But another way of looking at that is these are kind of the evergreen processes. There is universal health coverage, and what you want are surgical services in packages of priority services for UHC. Because this issue of financing, once a country, universal health coverage is one of the most powerful policy commitments that a country makes. So that's the definition of UHC. If you have a package, fine, you can have a package, but associating that with a policy commitment to making it available universally, that the coverage is for everyone. So the U and the C. Getting in that box is very, very important. And so from the WHO point of view, that is one of the main things we do for working to get all of these services to people. So for the first time, we have on our UHC service planning, delivery, and implementation platform, we have all of the surgical services across the health areas. We have all of the equipment and supplies that goes along with that. And more recently, we have these surgical packs and kits so that when a country looks at services, they automatically get the kits that are associated with them in terms of the resources required for implementation. That may all sound very wonky, but it keeps it from being invisible. It associates services with the resources needed to deliver them, and that includes with the health worker competencies. And we can talk more and endlessly about UHC, but that is one powerful thing. And so WHO works very, very mechanistically to get these services incorporated into priority packages for UHC. The second thing is national health strategic planning. So verticalized planning can work where you have a committed minister who's a surgeon who is already a believer. And that is fantastic. As you heard from Ghana, that can be a fantastically successful entry point. In other places, there may not be the readiness to do that, in which case you generate priorities, locally specific action priorities for getting surgical services to people. And those can be framed in such a way that these 3 or 4 are intended to be incorporated in the National Health Strategic Plan. These 3 or 4 are intended to be incorporated in the Ministry of Health's 5-year operational plan, et cetera, et cetera. So you need to surf the wave of what's happening, focus on some of these evergreen concepts like UHC and National Health Strategic Planning, and become part of those. Models of care is another very powerful one. We work a lot. I work in an organization that is really oriented towards the lower levels of the system, the interface between people in the system. And it takes a lot of advocacy and work to get WHO to focus on hospitals. So this is what I've been working on for a decade at WHO, is looking at these relational elements between people coming into the system and optimizing their movement across the health system. So models of care, which are made up of packages, platforms, and pathways. So these are other concepts. Don't use the word surgery, but that's what it's about. That's how you get these services to people. And that for us is what the eco continuum is about. It's not about anything else. It's about that these are services that are interdependent in all settings and need to be planned together at the national and subnational level. So it's a policy and planning concept. And to that end, the last thing I'll say is we're currently in the middle of, there's a very rigid governing body process. Some of you know about it, some of you don't care about it, reasonably so. But that about how we go from these high-level resolutions to a slightly more concrete global strategy to a bit more concrete action plan. None of which is at the level of the concrete actions that Carolina and Neva are taking. But I want to point out, so you have your professional entry point that it may be very important to you in terms of your identity. It is extremely important to me that I'm an international civil servant. That's the professional hat I've chosen. Nema is a surgeon, and she's actively a surgeon, but what she just, the center of her intervention was about signing kids up for health insurance, which is one of the classic old school public health interventions in the world. So through your chosen professional identity, you can come into these classic public health strategies and maneuvers. And that is what this upcoming global strategy and action plan is about. So we did a long period of expert consultation that ended in December. We are currently in the middle of the regional consultation period that just ended, I think, 3 days ago. The regions have submitted, and now it goes to a formal in June. We now have a hiatus period between now and mid-June. In mid-June, it goes up on the web for formal member state consultation. And that will give us some high-level areas to rally around. It doesn't explicitly include or exclude anyone's very small concrete activities, but it gives all of us a hell of an advocacy foundation. And it helps organize us, and it gives us a common language. So I think that is, it has some importance. Let's say it's not everything, but it's a very good substrate for action. And then following that, we'll be able to move it together to a global action plan. And so we have a couple of mechanisms to do that. The Acute Care Action Network you've heard about. So for anyone for whom those are your chosen actions, WHO is here, and we're really, really happy to engage with you. For those of you who love to figure out which surgical instruments go with which procedure, we would love to put you to work, mapping these things out to the UHC planning platform. So please just reach out. We want to hear your direction. We also want to ask for your help. And I hope that it's going to be exciting, I think, to all work together towards turning this, already it was, turning the resolutions into global strategies, and now the global strategy into an action plan.
Thank you very much. We are smoothly progressing to the end of this panel. If you allow me to summarize for the audience what we have been saying. So we said that surgery is an integral part of all properly functioning health system, that in the past 10, 15 years, a lot have been done to set up the foundation. It's a good stone to build on, so we have to keep the momentum. So we saw that there are still some gaps between properly written policies and implementation in the field, that we have to bridge those gaps and quicker. We also discussed that we all dream and hope that the next time when we sit somewhere like here, we'll be celebrating that probably our goals, our plans have been implemented fully, and that we will be living in a world where everyone needing surgery get it timely, on a very acceptable and affordable prices, and of very good and safe quality. So if I forget something, so you can link out with the panelists in the rooms there and around the coffee, and then you chat more. So over to you, Ruben. Thank you very much, and thank you for this amazing panel. That was really fantastic. You made my evening. Thank you.
Thank you very much. Thank you. That was a terrific panel. It was a treat for us to listen to these experts and hear the wisdom. So while they're taking their seats, let's give them another round of applause, please. We're blessed to have WHO representatives here. And one of the mandates and pillars of WHO is partnerships. And if you recall, Millennium Development Goals, number 8, was partnerships. And the Sustainable Development Goals, which in reality are still in existence till 2030, number 17 is partnerships. And we're very honored to partner with Operation Smile for this great event. We're very honored to partner with ministries of health that come, and we work with them day by day, and we're honored you're here with us tonight. But we're also honored to partner with each and every one of you. It's all of us working together in the member states, in the regional offices, in our academic programs. Everything that we do, our partnership is fundamental to getting across the finish line for global surgery. So thank you for being here tonight. The next part of the agenda, I will not hold you from your cocktails and coffee or whatever it is. But we won't have time right now to ask the panelists questions, but you're welcome to corner them during cocktail hour. Ask questions. Terry has volunteered to stick around for extra questions. And but thank you for being here. Please enjoy the rest of the evening. Good night.